Okay, let's get started, I think is where I was. And we have, I want to go through some of the stats. It should not come as a surprise because we've been going through these during the year with cases that have been outstanding. But we have the medical examiner, Palm Beach County medical examiners numbers for 2022. And these are there are no pending cases, so these should be the final numbers. Now, the medical examiner statewide through the FDLE won't be releasing their report until late November, early December. But these should be the numbers or within one or two for Palm Beach County. The good news, we are 19% down from our numbers in 2021. And in 2021, when everybody was going up, we were 13% down in 2021. So we are definitely going in the right direction. As you see up on your screen, in 22, we've had 421 opioid OD cases. Okay, and that's 76% of the total number of drug overdoses, deaths. Fentanyl was 93%, 391. So we do know that that heroin is a quaint reminder in the past when drugs were not as lethal as they are now, because there ain't no heroin on the street anymore. It's all fentanyl. Also, fentanyl, as you know, is polluting other street drugs, and so it's a incredible danger. And it shows by the 93% of the opioid overdose deaths show the cause or presence of fentanyl. And xylazine, tranq, that we had 40 overdose deaths. Now that's non-opioid. But xylazine, we have 40 from 2022. And of course, the new fentanyl analogs, NPE, which wasn't even tested for in 2021, we've had 20. And that's 20 times more potent than fentanyl. And fluorofentanyl, we've had 100. Last year we had 6. So that analog is very, very much present. The next page, we have a partial 5-month for Palm Beach County fire rescue transports, and the numbers are again trending down for overdose transports to the hospital. In 2020, these are the first 5 months. So each of the years, we're only doing 5 months as a comparative. So we're down 19% in the first 5 months of 23, whereas we were up 10% in well, I think I've got that mixed up. We were up 10% in I'll have to rework that percentage, but we were 19% down in 20 so far this year, 23. The net change, if you look at the 5 months, first 5 months for the last 6 years, we have a gross 60% reduction in transports. If some of you who were here at the very beginning and remember that fire rescue in Palm Beach County, now this represents half, 50% roughly, of the transports in Palm Beach County. We don't have the municipal numbers, but it's using Palm Beach County Fire Rescue, and they keep very, very good numbers, is very helpful because we know 50% and we know the trends. But if you recall back in 2016 and 17, when we asked Palm Beach Fire Rescue, they estimated it was $1,500 per transport. They had to send 2 trucks. They had personnel, overhead, all that kind of stuff. And so the amount of money that the county is saving when we're down from 1,278 calls in 2017 to 517 in 2023, I mean, that's stellar. And so again, it's another thing. We're going in the right direction. A lot of that, we've got Narcan that's readily accessible now. So that's a great help. We also have the addiction stabilization unit, and I don't want to steal their thunder about what's happening in South County, so I'll just leave it at that. But we have harm reduction methods that are, I believe, contributing, as well as getting rid of triple digit bad actors with prosecutions that we've taken in the last 6 years. So with that, let's move on to FAR. Heidi, you have the current numbers from the changes from the last 2 months.
Yes.
Can we get that on the screen?
I think Heidi's going to share her screen.
Oh, Heidi, you're going to share your screen with us?
Sure, I can do that.
All right, that'd be good.
Bear with me, let me get there.
Oh, wait a minute. Let me get off my. Okay, go ahead.
I have several screens open, so just give me 1 second. Okay. Okay, do you see that? Okay.
Yes, thank you.
Thank you. Okay, so I'll just start from the top. Currently we have 8,148 beds in the entire state. I just want to point out that's a 517 bed increase since last year. We've increased our MAT capacity as well. That trend I'll show you a little bit further down. But we have 1,724 units throughout the state. Out of the 8,148 beds, mostly levels 2s and 3s. 5,179 of those beds are level 2s and 3s. Level 4s, our bed capacity for level 4s has increased this month as well, up to 2,969. As far as the state trend goes, I could go into reading all this out to you, but you could see it. I just want to point out some things that have increased. Miami-Dade bed count has increased. That's increased our MAT bed capacity across the state. Some of the lower communities have increased their bed count. Sarasota, for example, that's increased since last month tremendously, well, by 11 beds, 11 MAT beds, which we didn't have any before. The overdose numbers that I have are for April and May, so it's that's the data that I have available. And for April and May, we had a total of 14 overdose. Four of those out of the 14 were resulted in death. That's a 28% rate of overdose fatality in FAR certified homes. 12 of the 14 were opiate addicts. There was 1 cocaine addict. 3 of them were alcohol. 1 was anything and everything. Everything was pretty steady as far as Boynton Beach had 1, Coral Springs had 1, Delray, we had 1 down there, Pompano Beach, and 1 in Jacksonville. The number of doses of naloxone given were, substantial. In 1 case, there was only 1 dose given, but we had 1 incident where 4 doses were given. 2 of the incidences, 9 doses were given. No, 2 doses were given in 9 of the incidences. 3 doses given once and 4 doses given to 2. Individual was from Ohio, 2 from Massachusetts, 1 Indiana, 1 Kansas. The rest of the incidents that came through were all Florida residents, which I was surprised about that. And that is what I have there. We're ongoing, we're committed to maintaining quality standards and upholding FAR's recovery services, an effective strategy to meet the expanding needs of our providers. Our mission to create, monitor, evaluate, and improve standards for recovery residents in the state of Florida, to maintain the standards set forth by NAR, National Association of Recovery Residences, and to maintain a forum for exchange of ideas, problem solving, providing guidance for our members. Our philosophy: we believe in high quality of care for chemically dependent individuals and other persons needing recovery residence services. We believe that this can be achieved through maintaining standards of care that are designed for that purpose. We also believe that all people deserve to recover in an atmosphere which meets their special needs as well as their basic right to safety, dignity, and respect.
Okay, thank you, Heidi. My
Yeah.
hats off to FAR.
Thank you.
I'm doing a roundtable in Washington DC on Friday. Frequently, I'm doing presentations out of the county and out of the state. And I got to tell you, by far, no pun intended, FAR is alone in both the number and the quality of your oversight and your assistance. The fact that you're over 8,000 beds now is fantastic. And no other state or group of states comes anywhere close to a third of that. We're going to have a FAR 3.0 coming up in just a few minutes. And I think, Heidi, you're taking lead on that along with Michael Cabot,
Yes, sir.
the director, and lots of good stuff for the future. And right now, anybody have any questions about the numbers or comments?
There's a question in chat.
There's a question in chat.
Yes, Maureen Killian has she made a statement.
See any? Oh, there it
There
is.
it is.
Okay. All right. Maureen Killian has a question. What is the impact of PBSO? Our guest LE in Palm Beach County carrying naloxone. Can we get the report Bradshaw alluded to in his press release last year in 2022? I don't know. You'll have to ask PBSO about the report. It can't hurt to have PBSO have Narcan, naloxone. So got to be a good thing. I don't know what the numbers are. I can ask them, maybe come in the next meeting. Oh, and I did have a question myself for Heidi. Did you take a look at, are we doing any better in outreach to get mat-friendly beds? I think we were at 37% of the 7,600 plus beds in Florida were mat beds. How are we doing on that?
We're doing well. We are making a very, I don't want to say an aggressive effort, but we're making a very strong effort to educate our providers to expand mat-friendly beds, and bringing to their awareness a safe and effective protocol in which they can effectively manage medically assisted recovery. And also we want to make sure that they have the knowledge that it's, federally somewhat discriminatory to not be mat friendly.
Okay.
So we're expanding and we're educating. That's our goal.
Thank you, Heidi. Any questions, comments? Okay, Lori, let's hear about Oxford House. How are things going?
Hello, Al. All right, let me share my screen. So, hold on. So as of May 23, we have a total of 137 houses, 1,252 beds throughout the state, 86 men with 788 beds, 28 women, 246 women's beds, 23 women and children's houses with 218 beds. These are currently the cities that we have Oxford houses in. They're kind of scattered throughout the state. And then these are the cities that we're looking to expand to in the near future. The overdoses, since the last meeting, we had 1 non-fatal revived with Narcan and 2 fatal. And then also since the previous meeting, we had experienced a single fatality of an uncertain origin. So we don't know, there was no drugs or drug paraphernalia found in near or in the house or with the person or on the person. So we're unsure of that outcome of that fatality. The second annual Oxford House Florida State Convention took place in Orlando in May with the participation of over 260 Oxford House members from various state regions. Oxford House Florida State Association Reentry Committee continues to help people transitioning from prison with acceptance to Oxford houses and providing post-release resources. And we are preparing to send at least 100 members to our 2023 World Convention in Maryland. Our upcoming events, the 2023 World Convention in Maryland, and then the 2024 World Convention in the fall of 24, which will be in Orlando this year. And then all chapters in the state continue to do Narcan administration trainings, and some areas are designated to Narcan providers in the iSave Florida database. And then here is our contact information, the websites, my contact information, and then Michael McKeogh's contact information he's the regional manager for Florida.
Okay, thank you, Lori. Can you send Marianne a copy of your stats for this meeting so we can put them up on the website along with all the other attachments?
Yes, I think I forgot to send them last month too, so I'll send them both.
Okay, thank you. And well, hats off to Oxford House as well. Those of you who were with the task force in the early days, I think the total number of Oxford houses in the state of Florida was 0. So this is quite an encouraging I look forward to the announcements because it seems like both FAR and Oxford House are expanding every time we have a meeting every couple of months. So excellent. Thank you again. And let's
we did complete our annual survey, so I will make sure that I have, and it's going to be from 2020. No, I think it's from 2023. So I will have those statistics for the next meeting along with this report. And it shows the percentage of people that live in Oxford House that are on MAT, certain demographics, age, things like that.
Oh, that's awesome. Thank you. And if you would, if such a document exists, I'd like to know the comparative of where Oxford House exists in the other 50 states. How many units and beds in those states? I mean, it sounds like we may be among the top in the country, just like we are with NAR standards and FAR. So like to have that information for the next meeting if possible.
Okay.
Danny,
so you just want the amount of houses that are in each state?
Houses and beds, yeah.
Okay. Yes, I think we can get that.
Okay, great. Any questions or comments? Okay, now let's move on to agenda item 3. I don't know who's going to take lead on this, Michael or Heidi, but let's get the update on what's going on with FAR. Very exciting stuff going on right now.
Would you like me to share my screen?
Please. And are you doing this solo, Heidi, or is Mark on the meeting?
No, I believe that Michael got a
Michael.
conflicting appointment today.
Okay. Well, yeah, he does have a day job.
Yeah.
Some of us
Yeah.
do.
Yes. All right. Bear with me just a moment while I figure this out here. Okay. Okay. Can you see my screen?
Yep.
Okay, great. So yes, FAR 3.0, our new rollout. We're going to be rolling out FAR or NAR standards 3.0 in September. But this is, just some reorganization, structural changes, some procedural changes that are taking place. We recognize the importance of drafting and implementing policies and procedures that not only meet national standards, but uphold resident rights through the proper consent and practical protocols. Therefore, FAR has developed templates that providers may use as guides for drafting policies and procedures, staffing documents, and resident orientation handbooks. These templates are available for levels 2, 3, and 4 providers to assist with the expedition of the certification process. The new service is geared toward all new applicants. However, certified providers may access the templates as they have been developed to complement them with the NAR 3.0 rollout of the NAR 3.0 standards. That again, as I mentioned, that's going to be later this year in September. And so we want to have a baseline set up for the minimum standards. So when they have questions or concerns, they have a template to use as something to go by. And see our new assessment policy. We're doing, we're streamlining all our processes and procedures to make things more efficient and more effective overall across the board for the organization and for the providers. And one of the things that we're requesting is, again, going back to the value of time and efficiency of our providers. So what we do is we're asking the providers to send their resident orientation handbooks prior to going to the assessment. And we have an opportunity to review the handbooks ahead of time so that when we're on site, we have more time available to consult with the providers. And that goes back to expanding education for medically assisted treatment and medically assisted recovery. Is, if we can do things in a more efficient and effective manner, we have more time to provide training and education to our providers on site and getting them informed of the protocols, the proper and safe protocols for medically assisted treatment. So our renewal policy, we are, again, with effectiveness and efficiency, we're contacting our providers 90 days in advance prior to the expiration of their certification, and we're scheduling the on-site renewal. So we're 90 days ahead of the game. This ensures that staff, we have time to invoice, schedule, and assess the request and do any corrective action necessary prior to the actual expiration of their certification. We're working to make the certification portal more user-friendly and a more pleasant experience. We're updating our software for anyone who uses the platform. Software upgrades will include new features to ensure providers have easy access to reports, forms, policy templates, and compliance tools, as well as training. More details about that are going to come in the following months. Training videos. We are in the process of developing training videos that will be available on our website. These videos will cover a variety of relevant topics that will be relevant to providers and residents, emphasizing the medically assisted treatment, the recovery-oriented systems of care, and information about the certification process. As well as we want to, some of the most important topics, we are developing training videos to cover like a Q&A style information session. We also have 4 sessions scheduled throughout the rest of the year for training for our providers. So the other thing that we're implementing this year is FAR no longer requires documentation of program fees for residents receiving services under a Department of Children and Family day-night with community housing license. It is FAR's position that housing program fees are not required as separate payment by patients to stay in attached program housing. FAR will no longer require program fee logs or rent logs for any clients that are provided services under said license. A provider offering services under day-night intensive outpatient program or intensive outpatient or outpatient program license will continue to be required to produce records of any financial obligations for any client receiving services under the DCF license. Clients who receive services under these licenses should be charged a fair market rate for housing and any other services provided that is not covered under DCF licensure. FAR does not define what fair market is. It will be up to the provider to determine that. We brought on new staff. Kayla McKinney is our new office assistant. Christopher Nino is our field assessor. There's myself and Josh Thrasher, who's still our certification administrator. For those who do not know Josh. And that is what I have for our update for FAR 3.0.
Okay, John Hewlick, what's the status of the Palm Beach County staff member that's going to be embedded into FAR? How's that going?
Yeah, we we had a meeting with FAR. Gosh, I'm confused whether it was this week. I think it was this week. But anyway, we're all set. They're under contract with us currently through September 30, 2024. So we're going to extend that to another year through, I believe, September 30, 2025. Emphasis on building out in Palm Beach County MAT capacity, deployment of recovery capital indexing training, and deployment of recovery capital indexing within the recovery residence capacity in Palm Beach County as well. So we're very excited with this partnership. We definitely think it's a critical piece to our efforts in terms of the recovery-oriented system of care work that we've been doing now. So that's the update.
Hey, thank you. Any questions or comments? Yes, I see Nancy, you've got your hand up.
Yeah, hi. I was seeing the numbers with FAR in the MAT beds in Palm Beach County, which reflected around 1,200. And because we have been doing so much work with FAR housing on our programs, I just wanted to ask Heidi if there was any new information as far as the classification of medication-assisted recovery, because we know there are not 1,200 beds that take all medications. And is that going to be addressed at any time on the website? Because it just says MAT, but it doesn't specify which medications.
So Nancy, if I may, I'll address this.
Mhm.
This is part of what FAR has been doing in terms of starting to educate people. It is very clear to me, the law, and certainly FAR's position, that the operators are not medical licensed providers. And so they should not be the ones that determine this medication is okay, but this isn't. So, it's going to, unfortunately, there is, of course, resistance out there. So there's a couple of things. It is FAR's position that it's discriminatory and it's in violation of federal law. It's also, in my opinion, practicing medicine without a license. So having said that, FAR is trying to do what we can do one day at a time to reach out to those providers. So specifically, I would say to you, Nancy, if you have experienced a provider that's saying, oh, they can only take X amount of drugs, otherwise they can't hear, you need to let FAR know, okay? Because there is action that we will take directly at that provider. And, at the same time, we're not trying to be the police, if you will, but we are trying to get everyone's mind and understanding of what their legal obligations are with respect to this.
Okay,
So we've
thank you.
spent a lot of time talking about it, but I'm going to say it again. We need to know if there is a specific problem with a specific provider.
We will let you know. I was just, the numbers themselves can be misleading. That's all.
That's
Yeah.
incredibly,
That's
thank
it.
you, Nancy. That's
Thank you.
incredibly important. Especially since we're doing well in harm reduction, reducing opioid overdose deaths, in part because of programs like the ASU and the work that Rebel Recovery does. We're actually going to have a presentation or at least an update from the National Association of Drug Court Providers, who are here in town, because they have a grant that they're trying to implement in Palm Beach County to work with arrested individuals who are not a danger to the community that can be released to the ASU. And, let's face it, housing is such a critical component of recovery that it's got to be incredibly frustrating for Rebel Recovery and for the ASU when somebody is willing and able and participating in a program through the ASU and they're homeless or they're living in a terrible neighborhood where the drug dealers know their number and their name. So this is of the highest importance, and we're working behind the scenes to try to get all those billions and billions of dollars of opioid funds that are being released to the various local governments or spent by the state. And other than Palm Beach County, who's ponied up, partnered with FAR, it's housing is not in the conversation. It's just all over the country. It's like, it's a lone voice in the wilderness. Housing. And so hopefully we can get that at least more to the front because it is critical. I did have a question for you, Heidi, about level 4s. You were mentioning about how you're treating them a little differently. Let me ask you a question, because this is an incredible increase from in the last couple of months. What do you say? It was about 500 additional beds in the state of Florida. Are you seeing an uptick because of the new legislation? Are you seeing an uptick in level 4 providers who are certified?
We're seeing a tremendous growth increase. And I think it's for a number of reasons. We're streamlining the process. There's more, with the referrals and the legislation that's being imposed, that's definitely, an influence for sure. So I think all of those things factor into play.
Good. It's nice to know that some of the legislation we painstakingly come up with and push in Tallahassee actually has some positive results. So that's great.
Hang on.
Yes. Okay, thank you. All right, seeing no further hands or questions or comments, let's move on to now. This is a treat. Dr. Annie Peters is with us. I thought that she had already given a presentation. I can't remember what I had for breakfast. Okay, so please forgive me for that, Annie. But she's here to give an update on FORCE with the NAATP, and take it away. It's all yours.
Great, thank you. And hello, everybody. I'm Annie Peters. I'm the Director of Research and Education at NAATP, which is the National Association of Addiction Treatment Providers. I presented to this group a while back on NATAP's FORCE outcomes program, but I wanted to give you an update because we have released our first public summary of the results of what we're seeing in the data. And so I'm gonna share my screen. I'm gonna zip through these a bit because I think you're probably familiar with the outcomes program, but just to give you a brief overview. So I'll zip through those and get to the recent report because that might be most interesting to you. So let me pull this up. So you can see my screen?
Yes.
Great. So essentially NAATP created FORCE as a 501c3 nonprofit to help providers of any type of service to collect or to pool their data together and start looking at it from first a quality improvement perspective, and then also from a research perspective. So it is a data repository, and I'll tell you what is in it in a moment. There's no cost to participate. We look at outcomes of addiction, and I can tell you what I mean by outcomes since everyone defines that differently. Outcomes of addiction treatment and recovery support. We look at social determinants of health and how those impact outcomes. We've look at multiple pathways, including we have folks in our database that provide only MOUD, only abstinence-based 12-step, and everything else, including all the full continuum of care. And our goal is we have a number of goals, but one is to help providers demonstrate their value and show that what they're doing is helping people. And then ultimately to help NAATP advocate for parity and equity and help providers with reimbursement those are all goals. This is essentially how it works. We have a data repository. It is fully de-identified data. There is no protected health information in there. We collect the data is given to us from an electronic medical record and that has been mostly what we've been doing. But I will say, particularly relevant to sober homes, is we are currently onboarding a couple of mobile apps. We know that some apps are being used to collect data in sober homes and other recovery support settings of various types. And so we're pretty excited about that because they're finishing up right now. And so we'll be able to accept data that is not from an electronic medical record, so that is given to us from another source. So that'll be really exciting. Obviously, it's not apples to apples comparisons between things like sober living and treatment, but it's exciting to be using common measures and standardized measures across different types of care. And then reports to providers. The summary report is out now, as I mentioned, and then in the next few months here, we'll be delivering individualized reports to each of the participating treatment providers or service providers. This is where our sites that submit data are located across the country. So we have a pretty wide spread of participation. You can see there's a mix of for-profit and not-for-profit programs. So they're very different in nature. I do have a list here of all the participating programs. Some of them are very large, multi-state centers, and some of them are really small, even 6-bed programs. So we're really excited. This is something that it's odd that a membership association starts something like this. That this is coming from the providers themselves saying we really want to look at our data, be transparent with our data, and demonstrate what we're doing and be open about it and do research on it. And this is something that the field really needs. And also working to standardize measures and look at outcomes collaboratively is really exciting. This is what the kind of data we have. We have, as I said, it's all de-identified. So we have a little bit of information about each patient in each episode of care, the service provided, the length of stay, the level of care, the type of service. And then for outcomes, the outcomes we're looking at I don't have treatment completion in there or completion of care. So discharge type is a proxy for outcomes. Did they complete or not? And then their substance use, both during and after services, their functioning, their mental and physical health, and their quality of life. And so the way we measure that, we accept all of those measures that are listed at the top. So any provider that uses the BAM, the BARC, the GAD, the PHQ-9, and there are a couple other ones there. And we're very flexible in what we accept. We recommend certain measurement periods, and that's how we report the data, but we don't require use of any one instrument. And so the data are very messy, but we're able to block it into buckets of time and display that, display the findings over time. And I'll show you a little bit about that in a minute. These are the connected tech partners we have now. So these are the ones that have fully connected to our API, which is our sort of the digital highway we use to get data. And so, but as I mentioned, there's a number of others that are working. I think Team Recovery is one of the apps that's really close to being finished with integrating with us. So that's really exciting. And there are others working on it as well. Sunwave just completed their an EMR. There you go. And then this is what we have. So we have 75 providers participating across the country, just short of 180,000 unique patient episodes of care, and a lot of surveys. And you can see that the most commonly used survey across the sites is still the PHQ-9, which is a depression screen. The BAM is the most frequently used measure that's related specifically to substance use disorders. So then this is just the front of our annual summary. I'm happy to provide the link. In fact, when I stop talking here, I can put the link in the chat. This is publicly available. It's provides a description of what Force is, what we do, why we're doing this, why it's unique, and then present some of the preliminary findings from the data. It's for patient episodes that occurred in 2022. So this is the summary of 2022. And it's across, at the time that we pulled the data, it was 55 treatment centers. So I'll just flip through some of the findings. Just, there are a couple of treatment centers that are sending over 20,000 patient episodes, and you can see there's some centers that are sending very few. So it really is an interesting set of data that is largely represented by some of the larger organizations. The domains we're looking at in our outcome, in our preliminary findings are essentially who are our patients, what levels of care are offered, and what are we finding as data takeaways. So this is across everyone. And the interesting thing so this is across 153,000 patient episodes. The interesting thing is, this tells us that not everybody is, there's 9% missing data, but also not everybody has inclusive categories for gender. So even transgender, which should be a higher percentage based on the percentages in the general population, the percentages are very small, 0.12% overall in the data set. So this really speaks to the need for standardization and inclusion, because a lot of EMRs have hard-coded gender categories that don't include diversity, just male, female, and sometimes other. That's changing, but we're seeing that it's not changing across the board because of what we're seeing in the data. Race and ethnicity, we're finding a lot of missing data, 42%. And what we're hearing is, oh, that's in a different part of the chart, or, oh, that's asked in an assessment, or it's not always completed. It's just amazing to think that there's so much uncaptured race and ethnicity data. We've even heard some providers say our staff are uncomfortable asking the question. So I know. So there's a lot of things we're finding out as we move through this this program. So this is just some snapshots. Overall primary diagnosis that we're seeing is 49%. For opiates, it's about 19%. Opiate use disorders are more represented in the higher levels of care than in outpatient. And co-occurring mental health. Now there's a lot of missing data here. So not everybody is reporting a mental health diagnosis, but of the 17,000 episodes that we have mental health reported for, 92% are reporting a co-occurring mental health diagnosis. Obviously, that's a bit biased because if you're not collecting the data point, if you're collecting the data point, it's probably because you're treating or paying attention to mental health issues. Most common is anxiety. Depression is a close second. So can see those there. Length of stay by level of care. This is the average across 116,000 episodes. Seeing the average length of stay in inpatient, residential, PHP, recovery support, IOP, and outpatient. And these are calendar days spent in each program. And then discharge type. This is really interesting because we're seeing that treatment completion is higher in both the higher levels of care, like detox, residential, and PHP, and also in recovery support. So a lot of completed treatment, 50% completed treatment in outpatient, which is an important finding. Those are AMAs, and then adding irregular discharge overall and other types. And then I'm just going to show you, these are small numbers but it's the question people often ask is return to use. And this is obviously not a data point that, harm reduction programs would ask, have you relapsed? But this is among some residential programs, they really want to ask this question. So that's a question on the Force Outcomes Survey. And of the folks that are using that, we have 6,000 patient episodes, and seeing that, the relapse for AMAs is about twice as frequent, which we could have expected, that people who leave against medical advice are more likely to report a return to use after discharge. And then substance use days of use. This is in days post-treatment. We have 3,000 patient episodes here showing pretty low days used in the report in those that responded to the survey. Post-treatment, we know is really hard to collect data from people. We do have some treatment programs that are getting 80% response rate on their post-treatment surveys, and some that are getting 2%. So this is a very biased look but it is the data that we have. And symptom scales, this one is interesting, showing the decline in symptoms of anxiety and depression throughout. And really the admission to discharge is the most notable, because that data is pretty complete, because response rate is high because people are in care. So we know that, and this isn't a change in a person. This is cross-sectional, just so because we're not following an individual. So it's at admission, this is the average score, and at discharge, this is the average score. But it's still pretty interesting, showing moderate levels at admission and in the minimal or mild, almost minimal levels at discharge. And then this is my favorite finding, particularly because, so the BARC is the brief assessment of recovery capital. We talked to Dr. Corey Vilsant, who's the first author on the BARC. She's on the Force board. And when I sent her the report, and she said, wow, look at those recovery capital scores. She said that admission recovery capital score 42 is what we're seeing, not just in beginning of substance use treatment, but also in ERs among people who overdosed. She said they see, that about that level of recovery capital. And then the gain to the score of 51, she said that's approximately the recovery capital reported by people who are in the general population and have 11 years of recovery. So what that's saying is that it's a very, very big change from admission to discharge. And this is over all levels of care, so it's averaged, but we can parse this down as we get into the data more and find out where are these gains happening most robustly. But it is exciting to see that recovery capital is really improving over the course of care. Lots of missing data. It was actually not as bad as we thought it would be, but you can see the types of data that we're missing. We want to be very clear and transparent about what we have and about how it is messy because it is from over 50 providers. So, you know, standardization is really one of our goals, and that's why we're looking at this really closely. And these are our next steps. So next is sending out the annual site reports. So the reports to each participating site. Next is data validation recommendations so that we can get cleaner data. We're developing some research partnerships to do some retrospective studies into the data that are more rigorous. And then creating a dashboard for the providers to use to look at their data more frequently. And I think that is all. I know that was a whirlwind and hopefully the level you wanted, but I will stop sharing now. And hopefully that was what you were looking for and
Yep.
of interest.
Any questions or comments?
I have a
Hey,
couple
Dr.
questions.
Peters.
Okay, Dr. Andrick, you're up.
Hi, Dr. Peters.
Hi.
Actually, after last presentation that you had in the SOBR task force, we met and we actually seriously considered submitting BAMs that we collected.
Mhm.
But I think for some technical reasons between our IT, we
Mhm.
still didn't do that. However, I wanted to share with you that since that time, our model of functioning measurements with BAM was adopted to 37 other counties at state of Florida. So all of us are now submitting to centralized database in state of Florida. So I think there is a potential that I connect you with the state data gurus who are collecting that. And actually funding for this kind of model that is happening now is tied to submitting BAMs for all people who are receiving funding from the state in the model that I'm talking about. Not all state funding, but Department of Health funding that is undergoing right now in state of Florida, including using like those money that is coming down from most recent, like, you know, developments. It's going to be tied to their data submission. So I think it would be great success if they can dump data because you're going to have much more BAMs. That's one comment. So
Okay.
I think it's going to be very valuable. The other comment I have is the same way how you impressed with those 5,000 touch points from the recovery capital. I'm surprised you have so much more. Your denominator for BAM is so much larger than that. But like, you know, from BAM, if you extract protective factors calculations, it's recovery potential, right? Because it's the same questions like you have recovery capital. So BAM is different because BAM measured also risk of like other risks, right? So BAM is a little bit wider tool, measure not only protective factors as a patient, but risk of use and risk of relapse. So, but if you subtract that subsection of the BAM, you would have much more, you would have equal, you cannot compare them because the questions are slightly different.
Right.
But your recovery capital is equal to BAM protective factors questions. So you can have a slide with much larger denominator than 5,000 that you have now.
Yeah, that's true.
Right, in a BAM.
Yeah.
The other thing, I would be really careful when you're publishing those relapse data. And I wouldn't really pair them because what you are doing here, you're asking people to submit like mainly functional tools, PHQ-9 and they're not functioning tools for opioid use disorder or substance use disorder. Right. So when you publish something like that, it's like, it's kind of side product of your data. And I am not on your board, but I'm envisioning that would be discussion, right? You have much more tangible question. Did you relapse or not, right? And that's but the point of those data is really, this is relapsing illness and can completely give you a fake impression about the program who's submitting that. I think what we need, the purpose of this data, that we compare apples to apples, and that we have like one program. So what is, of all your universe, are those people getting more recovery capital? Are those people having more purposeful lives? Did they establish relationships with the families? Did they find a job? Are they living better life versus how many relapse they had? Because
Right.
relapse can completely misinterpret that program, because this is relapsing illness, right? And if they come back in a program and they're now becoming again part of the treatment, and like, in those big data, I don't know. I mean, in other words, for me, finally, we have enough data that we compare programs. That's my main purpose, why I'm so motivated that we really push those data submissions and comparisons and data analysis. Now in a phase of data analysis, and that's what we also have to reach uniformity, how we interpret this data. So if we are with this data reporting relapses, we are really undermining severity of this illness and theory of this illness. I think we should put that on the side, because you should really focus on measuring functionality of sustained recovery and different programs, rather than really asking them how many relapse you had. I mean, I know I'm confusing how I'm talking. It's a matter of much larger discussion, but kudos to you for pushing this. I'm very excited. This was very informative. But now that we have data, now is the ocean of work in front of us. What do we do with this data, and how we interpret this data?
Right. Yep.
Yeah.
And I just picked some.
Annie, go ahead.
Yeah.
Annie, go ahead.
Oh, I just to both of them, that would be fabulous to get the BAMs. I think if we can get a data set that has publicly funded treatment data and privately funded data, pre-treatment data, would be amazing to have in one section or one data set. And as far as I chose some things to report. People often ask about, what's the relapse rate? So I showed that, but as I said, that's a really small group that's using that tool, and only those who really are interested in that as an outcome have been using that. And it's much more frequent that people are using the BAM. And we do have the BAM results in the report, so you can take a look at that. And yeah, it's that's not one that is a common, which is great. It's not a common request that people want something that just looks at relapse, but it is still something that folks are looking at.
I know, but this is also for us opportunity to educate everybody who is willing to listen about this illness. So if we report on relapse, then we are still going back to that black and white. Oh, you went to 90 days treatment, you're cured. That's, for me, that's equality of that. I think, like, if we explain, hey, there is a data on that, but you cannot extract that from the whole treatment, I think it's opportunity for us to educate. That's why I'm saying we all need to be careful.
I hear you. Yeah, good point.
Being a non-medical person, one thing, when I started becoming aware of these issues, and one of the things that kept on reoccurring was the statement that relapse is a part of recovery. And one of the things I fear with leaving relapse out of the data is that it's kind of buying into a prejudice that it's a failure if somebody relapses. So, I'm not, I don't have a medical background, but I think one of the things with parity, with the entire concept of recovery, I think there's a bias and there's a prejudice when one talks about successes and one talks about failures. We all know that gaining recovery capital, in its purest sense, a job, a life, friends, something to live for, is all, if it's quantifiable, it's all positive. It's all, but you can't sweep the negative under the rug. but for sure, if you're gonna have data, you need to have universal data. So you can't have some providers reporting the relapses and others not reporting the relapses, if that's what I'm hearing.
Well, not everybody wants to use, and I'm glad, wants to use the term relapse. You know, this was that's a handmade measure by a small group of treatment providers that wanted
And
to
that's,
ask.
and that's what I was referring to. I collect data on relapses, but I put it for each, for my universe, I put it in a time frame. I'm measuring during the time. If they come longer to the program, is their number of relapses decreasing? I'm carrying 5,000 patients, so I have a huge universe. So that's valuable for the program to see. If my program during the time decreases, the more they come, the less chances. Al, I agree with you. Relapse is important, like to measure. I do, but when you do this anecdotally, that kind of is putting us back to really black and white measurement, and there is no really uniformity how we measure that.
Well,
So
you know,
that's,
yeah.
you know, we are trying to submit apples and apples. So
Yeah.
in functional tests, there is question in the last 30, 90 days, I don't know, remember exactly, did you use the drugs, right? That's kind of also can be measured as systemic, same question about relapse. And let's do it, but that's just question to the patient separate from the uniformed tools. Are you relapse for me is like really dangerous.
Okay, well, the day somebody starts calling it an oops, I quit, okay? I'm
Yeah.
done.
No, return to use, or, you know, even
Return to use,
better,
okay, I
just
get
the number of days you use drugs and alcohol in the past 30 days, which is
Correct.
Now, what
most-
what I'd like to hear is let's project out 5 years. I mean, you're expanding, you've gone from 55 providers to 74, 75 providers. You know, the sky's the limit. I mean, you know, there are thousands of providers in this country. They don't, in your data collection, they don't have to be members of your association. But where do you see this? How is this going to help? You know, I know we've been talking about we need data, we need data, we need data. I know insurance companies need data.
Yeah.
In order to actually, you know, rationally apply the coverage that they should apply, as opposed to just, you know, making assessments and judgments that are based on air.
Right.
Whenever I talk about housing to insurance companies as being, you should pay for housing, especially level 4. Level 4 is therapeutic. It may not be clinical, but for crying out loud, you got somebody 25, 30 hours in treatment. You're not paying for the housing. What's going on? And well, show me the data. So where do you see this going ultimately? I mean, peer review studies, what are we trying to affect? What are we going to affect in layman's terms?
The peer-reviewed studies are really like the currency we need to you know, the thing we always say in the FORCE program is that the currency we need to buy our rightful place in medical care is, you know, to demonstrate that we're seeing the changes we're seeing in treatment. You know, what is the process of a person's functioning changing while they're in treatment in different levels of care? What's happening to them? Are they getting more days employed, more days in stable housing, less use days? That's you know, having valid research studies published is really the goal. And so that's one of our key focus for us right now is developing research partnerships to take a good, rigorous look at the data from a specific research questions. So yeah, in 5 years, ideally, we have multiple research groups across the country digging into the data, publishing that these data are used for advocacy for payment, advocacy for policymaking, and advocacy to the public to reduce stigma, to say, you know, this is helping people are getting well. So, I mean, that's ideally what would be happening.
And if I can add to that, Al, I think that's a fantastic question what you asked, right? So that's what I'm talking about. We need now to reach consensus how we interpret this data. In the 5 years, I would like to see that this kind of data, first of all, we all submit the same data. We cannot, if you receive some kind of public funding, you should submit the same set of the metrics. And then when we all submit the same set of the metrics, you're going to be able to say, hey, this is like people that come in your program have more recovery capital, they have more protective factors than average. So you're doing really good job. So I, as insurance company, will pay you value based, the same way how I get more money if I have more diabetics with controlled diabetes or more hypertensive with controlled hypertension. I'm going to get the higher reimbursement if my program is doing better job and letting people have higher scores in their functionality in regular life. I don't care if they use marijuana on a lunch break, as long as they have like, jobs and drive car, have cars and kind of reconnected with the family. That's the functioning measure of this illness. And that's, I would hope that we have.
All right. Any other comments or questions? This is great stuff. There's another organization that worked with NAATP that I don't know if it's still, you're still working with Shatterproof or not. Shatterproof is trying to create a database that can show, how do I even say this? It's kind of like saying, a relapse or return to use or an oops. It's like, well, these are legitimate programs that have good data. And right from the start, one of the things, and Michelle Magnum was going to be on this meeting, but I don't think she is. She'll probably be here in 2 months at our next meeting. But one of the things that I replied, because this is like juggling Jello, okay? It's yes, you try to get the same data, you try to get the same apples and apples, and use the same protocols, and then you have a situation like, okay, let's try to figure out who the good providers are. And well, one provider may only accept people they don't think are at risk, because they want better data. So you may have, it's going to be hard to be able to identify, and we'll have this discussion in 2 months, to be able to identify who really are the good providers if you have some providers that are trying to get their numbers up by treating sure bets type of thing. So I think that's one of the problems that I've seen from a lay perspective in terms of how do you, and I think what Belma said is absolutely critical, is that the more data you have, looking at the same measurements, the same areas, then you can flesh out some of the, the outliers and really come up with a core that gives you a lot of information. Again, to me, I used to think, because people think this, because they have their prejudices, that a relapse is a failure. It's not necessarily a failure in treatment. It's not. It's, I come to find out, it's how long you're in treatment. What other measurements do you have? And so, yes, when we can have an easier time with parity. We can have an easier time with private pay. And that's one of the questions I did have for you, Danny. Do you see a difference at all in your data between your private pay and your public providers that are in the study? Do you see any difference there?
So we have it by, the data point is by individual patient episodes. Was this primarily from public funding, paid for by public funding, and paid for by private? And so we can look at that. We haven't been diving into that point yet, but we can see that is just separate the different episodes by per provider or overall for how was the service funded. So we are.
There are all kinds of issues, where you come from, what your resources are, can be determinative of success That's why the ASU, you know, they're in the trench, Rebel Recovery, they're in the trench with people who, many of whom have lost hope. They don't have supports. They may be homeless. They may be here from out of state where they can't go home. They're no longer welcome. I mean, those kind of things can be determinative of call it success, you know, staying in treatment and staying in recovery and increasing the and having recovery capital that goes up with treatment, responding to treatment. So I think that's one data point that I think everybody needs to keep in mind going forward is maybe it could be economic or social determinants. It could be it could be and you may be able to flesh that out with private and public. And that might be a good data set there to see if the numbers parallel or that graph goes off in strange directions. Any other comments or questions?
I would just like to add that, you
John.
know, I think what Recovery Capital offers us is an absolute common language. You know, I still hear a lot of treatment centricity and, you know, we talk of, you know, how long would we stayed in treatment when in essence, the predictor isn't length of stay, it's length of engagement. So, you know, the commonality of Recovery Capital, now we can argue, you know, BARC 10 and its deficits. You know, I can tell you from a decision-making process, I would throw up the 10 questions into the chat room and ask anybody in the room, you know, from a decision-making process and my role and how do you budget and plan, whether that tells me, you know, how we should be appropriating our dollars. You know, when you really need a lot deeper into the recovery capital world and, you know, much more and delve into more of the indicators and predictive factors around long-term recovery capital, I'll tell you our data sets begin to tell us what we already know in terms of our greatest risk factors being access to healthcare is the greatest risk factor to not achieving long-term recovery outcome. Nutrition, housing, the living situation, employment, financial well-being, you know, and the other things, sense of, you know, in terms of high resiliency factors, sense of purpose, beliefs, safety, values, sense of community. These are all predictive. The research has suggested this for decades. The fact that here in Palm Beach County, we're having these conversations, you know, teasing out this data, and more importantly, how do we take the data if you're, you know, a functional government, you know, we use terms like data decision, using data to make decisions. You know, we're actually, you know, applying those mechanisms here in Palm Beach County. So do we have a ways to go? I think, you know, absolutely, but we're all set in the, you know, certainly set in the same, going in the same direction here. So that's what I'd like to add.
Yeah, John, that's a great point because the length of engagement, it really is an art form as to how to describe these things so we have universal understanding. Because when you talk about treatment, and I know, John, you and I have talked about this, that as far as bang for the buck, when people used to think, oh, how many beds do you have? You know, how many beds are available for treatment? And that's the most expensive type of treatment you can give. You know, 60 days inpatient doesn't exist anymore unless you're from Beverly Hills or Palm Beach, in most cases, inpatient. But it's frightfully expensive, and you're using your resources, which are limited.
Yeah.
So I agree
And they
that
are,
we have to be on the same page when it comes to engagement.
and they are lower cost, much higher outcome interventions. You know, as you know, Al, the board just approved on May 2nd the full expansion of our network of recovery community organizations and centers throughout throughout the county. Those centers weren't established by accident. They were established very intentionally, and that is from a length of engagement perspective. So the county and our work and our behavioral health contracts our acute providers have historically needed to develop a treatment plan. They are now doing baseline recovery capital indexing. We expect improved recovery capital scores while in care, but they're also required to develop a individualized recovery plan, which is different from a treatment plan. Much more toward a meaningful discharge plan. We've gotten rid of successful treatment discharge as an outcome measure. It doesn't tell me anything. What we have incorporated, though, is our providers are expected to warm handoff to a recovery community center. They'll be measured on that successful handoff or not. And why is that? Because we want to be able to engage people as long as possible in that now non-clinical environment, and that we can keep a set of eyeballs, and I don't even like to use the word continuum anymore, because recovery is not that linear, but that we can keep a set of eyeballs, on an individual's care beyond the acute setting, which historically it has been virtually impossible to do so. So,
Well, thanks.
Yep.
Thanks, John. And I think the overall 10,000 foot is hopefully we can all arrive at data points that everybody's using and they mean the same thing. I guess that's one of the goals, because if we have NAATP using data points that somebody else has a different meaning for the data points or uses different data points, then we're not rowing together. We're rowing in opposite directions. So, Annie, thank you. First of all, great report, and keep us posted. So let's be on speed dial when you have something to add, when things, when you expand or have new stuff to offer, please come back. Okay.
Will do. Thank you, everyone.
And before we get into the legislative part, Belma and Ariana, I heard a rumor that something's opening up today or tomorrow in South County.
Is Ariana here? She's gonna
I'm
be the
here, but I have not been invited there yet.
No, so we are opening clinic next week in Delray. Addiction services, we're gonna start in August.
Okay.
So we need a minute to we just recruited team members and peers for that location. So I think August is the month, but it's gonna be official ribbon cutting. They're gonna all be invited. So for those that don't know, like Healthcare District is moving our existing clinic from Health Department building on Congress in Delray, just across the street, and much larger space. So we're gonna have separate entrance and separate kind of similar setting that we have in Mangonia Clinic with a group and centering and all that to our south location. So we are very excited about that. And we are working also with JFK South Atlantis, that we kind of imitate ASU on South that doesn't have official title of ASU, but we have peer there during regular hours and kind of find solution for extended hours. So we are working on that as well. So we are moving a little bit more south to provide more access to outpatient care in Healthcare District system.
That's great news, because one of the big impediments has been, as Ariana, as you know, transportation. Well, we have the hub now, but having a clinic in South County is huge. And having a semi-partnership with JFK, which actually receives the most transports for opioid overdoses in the county still, is a plus as well. So great news.
And then,
we'll be
and
looking.
my other update, I'm sorry, regarding that, we also signed a contract with FAU Psychiatry Residency Program. So starting July, we have 4 residents, and that's kind of Dr. Moran for you, interesting as well. We have 4 residents rotating at any given time, year 3 and 4 from their residency through our clinics. So they're going to be all they're going to be 2 of the residents will be in our Mangonia location, 2 of the residents will be at Delray location at any given point of time. So we will have sustained psychiatric coverage in both of those locations for general psych and people suffering from substance use disorders. It's not only for people suffering from substance use disorder, but we know all of them need psych, this is psychiatric illness. So that's kind of another exciting development. And it's going to be a lot of interesting, like, academical affiliation coming out of that, like, probably data-wise, publishing-wise. So it's exciting that we are getting that access to psychiatry through those clinics as well for all. So all of this call, if you need psychiatry needs, please give me a call. We need to establish referral process, and anybody from your clients should have psychiatric evaluation. Let me just know.
Awesome. Thank you. Thank you, Belma. I saw, John, you had your hand up. Do you have a comment on?
No, I was clapping on Belma's analysis.
Oh, you were
about
clapping,
the-
see.
About the psychiatric, coverage.
Yeah.
Actually, that's really great news, Belma.
Yeah, behavioral health has two sides, doesn't it? Okay. All right, great. Let's move on then to now we do have the drug court folks coming up in about 15 minutes, but let's get through some of the legislative I was hoping that the governor would have signed the our bill because it's been passed. The appropriation for a statewide study for housing, for community housing, also passed the legislature, but we don't know whether it's still in the spending bill, the budget, or it's on the cutting room floor. Won't know until the governor, till we receive the budget, and then we will know. With regard to the bill, if anybody knows the governor's staff or anybody on the staff, and you can reach out and say, hey, SB 210 is a really good bill. Marijuana doesn't need to be smoked in treatment. And the Department of Children and Families needs to start imposing at least, and collecting fines. That's basically the bill. Let them know, because the governor can do one of three things. The governor can sign the bill, governor can veto the bill. I don't think that's going to happen. Or the governor can sit on it and not sign it, in which case it won't become law. So anybody who has any inroads to Crazy Town, Tallahassee, please reach out and let them know that SB 210 is a bill that needs to be signed. Okay, getting to the 2023-24 initiatives. We have an early session coming up in January. So if we're going to do anything, we need to do it, with a bit of due diligence here. By October, we should have our legislation into the hands of legislators, senators, and representatives. So that means August is going to be the shredding month, the month that we really give you some samples. Two of the things that we want to, kind of aspirational goal, and I don't think we need to wait for the study necessarily to at least begin work on this. But Chapter 419, Community Residential Homes, is not well written, probably unconstitutional, or at least violative of the ADA and the FHA. And we need to rewrite that section. It's only basically 2 pages in the statute book, but I'm gonna hand it over to Jeff Lynn, and Terrell. Please chime in if you have anything to add as well. And what are your thoughts? What do we need to do?
Al, do you want me to start?
Yeah, please.
Okay. Good afternoon, everyone. My name is Jeffrey Lynn. I'm a regulatory attorney and zoning attorney in the south part of the county, representing many treatment providers, and a large part of my practice, for those who don't know, deals with what we refer to as level 4 homes as identified by NAR and FAR. Chapter 419 Florida statutes was drafted decades ago as a mandate by the legislature, actually through the federal government, to avoid the NIMBYism, the not in my backyard, the stigma, the prejudice to all types of group homes. And the way it was created it created a mandatory framework for zoning for these group homes, such that if you, as Florida, many states are followed suit, wanted federal block grant monies to cover these type of social services, group homes for people with all kinds of mental or physical disabilities. The thing is, if you want this money, you cannot be discriminatory, and these homes have to be in the most community-based setting possible. So that's where Chapter 419 came about, and Chapter 419 has a singular statute, which is called community residential homes. And if you read it, it's a very easy read. It only does apply to those homes where the residents of those homes are, and they use the term clients of, the various agencies, DCF, ACA, the APD, Agency for Persons with Disabilities. There's multiple agencies that provide through DCF and through ACA these group home settings, and the providers of those services are given taxpayer dollars basically to provide those housing services, and in exchange, those housing providers can locate without difficulty throughout the state. Clearly, sober living and necessary level 4 housing in particular should fall under that same paradigm. Dan Lauber, who you may have met through this group or heard, is been identified by many jurisdictions as an individual with group home experience, and he's drafted model ordinances that have been adopted by Palm Beach County. Delray Beach was the first, Pompano Beach, City of Fort Lauderdale, Oakland Park, West Palm Beach. I'm not sure, not that it matters if Mr. Baird's on the phone, Tom, he's a city attorney for some cities. Not sure if some cities he's worked with have adopted it, but it creates a different framework that is much more accepting and incorporating of, amongst other things, recovery residences. In the studies that Mr. Lauber prepared, he explicitly states that in his expert opinion, Chapter 419 is unlawful as drafted. And the reason it's unlawful is because it mandates certain separation requirements without any kind of relief being granted. And it's discriminatory. We don't need to go into why. It doesn't matter. It is. I'm telling you that it is under federal law, and Dan Lauber has agreed. So the state attorney's office and this group, this task force through its leadership, has identified that one of the things that this task force really is best suited to do is to take a stab at rewriting Chapter 419 to make it more modern. The reason that is probably more critically important than ever is that ASAM, the American Society of Addiction Medicine, is soon rolling out its next evolution of its placement criteria. And for the first time, they've worked directly with NAR, the National Affiliation of Recovery Residences, to identify sober living throughout placement, and has identified the need for sober living to be commensurate and ancillary with clinical treatment. And so with that coming out, it's supposed to come out this summer, but it's definitely coming out in 2023 once it's released. You could Google that, go to ASAM and find those criteria. I have it if you want copies of it. So that's what we're doing, is we're going to take a look and a stab at 419 to avoid the discrimination and to further encourage communities to accept sober living and to appropriately regulate it through FAR as necessary. That's also part of the appropriation, as you know, that I was talking about, that money be allocated for a statewide study. So rather than this being done piecemeal, it will be done as a model ordinance that cities are free to adopt, but at least won't be inconsistent from jurisdiction to jurisdiction. And we're hoping to get a start at that ASAP, particularly as Al said, we're coming up to a presidential election year, so the entire Florida legislative calendar is moved up by 60 days. And that's where we are right now.
Okay, Carol, do you have anything you'd like to add?
No, and I actually have to run off to another meeting, but I will simply echo what Jeffrey said, and I will further state that the Florida League of Cities was very supportive of the proviso and the Florida Association of Counties, and so long as this is not something that becomes mandatory for them and violates home rule or usurps their home rule authority, they welcome the ability to grab onto a statute that meets all of the federal requirements that they can use in their cities, so that way they are not discriminating. Because a lot of cities are just frequently lost as it relates to any kind of regulation of zoning in this space. And so some of them are getting in trouble just because they don't know what they're doing. And so they're looking forward to having some language out there that is kind of a best practice or provides, that guidance that they can adopt as they desire or feel the need to. And it will provide some consistency statewide, I believe, which will be helpful as well.
Well, wasn't there a jurisdiction, I think in Miami-Dade, that adopted a hybrid of Dan Lauber's ordinance, but got it all wrong? Were you?
Yeah, that's Hialeah. Hialeah didn't hire Dan, stole his work. We joke it's like a terrorist getting a nuclear weapon and having no idea how it's built, but just knows how to press the button. It's really bad, and it makes no sense. And that's part of the problem too, is that certain city attorneys are trying to get ahead of the curve, and their cities understandably don't want to spend more money. So there's no copyright in legal work, as you know. But yeah, Hialeah really did a number on it, and it makes no sense now.
Okay. Tom, did you have anything you wanted to add?
Yeah, I just wanted to add and build on Terrell's comments and Jeff's really. Cities have struggled for some time with sober housing and discriminatory practices that are being alleged or committed in some cases. And so legislation that helps to move us towards a uniform way and a better understanding of what cities can and can't do in terms of regulatory actions is very helpful. And I think it's a very good thing that we are moving in a direction of making sure that we have a statute that we feel is compliant with law and we know the guardrails that we're going to be able to operate within.
Yes, that it really will be helpful to get some kind of consistency around the state, and to actually work together. One of the things that we have to consider, and we've always considered in this task force, and that's why we have local elected officials on the task force. Like at this point, Mayor Weiss is not able to be here today, but we do have a representative of Virginia's with us. But we need to be able to guide a path through the minefield of the good citizens with the pitchforks and the torches, as opposed to the need for these recovery residences, so that we as a state and as a local community can benefit. Because a well-run recovery residence is, I believe, and I've read, accounts and studies. It is actually it's actually a benefit to a community, and I think maybe Lori can chime in, because Oxford House has been around for 30, 40 years or more, and it's been able to coexist with the community without much friction. So, that's our goal. A lot of the next meeting will be dedicated to, trying to get a good start on this. We may or may not get it into the legislature this next session, but we need to try. And any other comments or questions? Okay. You may or may not have heard Dave Ehrenberg is not running for re-election.
It's an untrue rumor. It's untrue. We're not letting it happen.
Oh yeah, well, I tried that. Doesn't work.
Oh, okay, sorry.
Yeah.
Unless you're taking his place, Al, it's an untrue rumor.
Well, there's an interesting irony that prevents me from running. And it has nothing to do with my desire to. It has to do with the state law that got passed, which I lovingly refer to as the Charlie Crist law. As you may know, Charlie Crist changed parties in order to run for Congress and then unseated a Republican in a congressional district. The legislature got angry and decided to pass a law that requires you to be a member of a particular party for 365 days before qualifying. Qualifying comes before any primary by several months. And I have been for many years and what's called NPA, no party affiliation, because I used to go up to the governor's office in my Don Quixote quest to become a judge, and every one of them was Republican. I didn't stand a chance, but I kept doing it. And then I became an executive director of the Commission on Ethics for a couple of years, so I never changed back to a party designation. So in Palm Beach County, you cannot run as an NPA. You won't get more than 10% of the vote. So that's why I ain't in it. But we have some good people in it from the office here. Maybe they haven't announced, but we know we're going strong until January 2025 as a task force, and that'll get us into the next legislative session after 24. Yeah, after January 24. So that but I'm confident that the next person who takes over will keep this going because it really has saved lives. You all have saved lives in Palm Beach County, and we are emulated throughout the state. Just look at the addiction stabilization unit. What do we have? Like 6 or 8 or 10 programs that are starting throughout the state that are emulating what Belma and her crew started. Along with people who are on the task force, like Houston Parks, and others that really made a difference and are making a difference in Palm Beach County. So whoever gets elected is going to be a fool not to keep this going. I'll go on the record with that. We have one more presentation, and I anticipate that they're supposed to be on at 2:45. We've just contacted them, the drug court. It's an interesting program that we're trying to institute here to bring and Belma is and the ASU are critical to this new process to get people who are in the Palm Beach County Jail a warm handoff to the ASU and to get them into treatment if they're screened and it's determined that they have opioid use disorder. So with that, I see, Tom, you still have your hand up. I think that might be from before. Yeah, okay.
Al, can I ask a question real quick?
Yeah, sure.
Sorry.
I'm trying to eat up 5 minutes, so go ahead.
Yeah, before we move away from legislation, is there any discussion on that email that I sent you a few days ago about the return of property?
Yeah, okay. Why don't you go ahead and tell everybody what you've encountered?
Well, I'm just saying that I get people contacting me a lot because they're, sponsoring somebody or whatever, and they know that I was involved in this legislation. And so it's just there's no enforcement. Nobody seems to care even when we present them with a copy of the legislation. And then the ones that do seem to acknowledge it, they say, well, they signed a agreement upon admission that we could keep their property up to 72 hours. And then of course there's no teeth in the lawsuit. There's no fines,
One thing we can do, well, I got to tell you, one thing, they're on the hook, if something bad happens, but I get it. We could look to amend, like we've had to do with day-night with housing licenses. We may have to go in and amend one more time to say that notwithstanding any contractual relationship entered into by a patient, and use that. I don't know how we can, we're not gonna make it criminal. That's just not gonna happen.
There can't be any fines.
Uh, um, I'll have to reread the statute. We could, but who's gonna fine? It's gonna be DCF. It's gonna be the department. You know, let's get it so that they're imposing fines, and maybe we will do that. One of the things, because we got, rightly so, we got a couple of questions when that legislation went through, and for everybody, it's the legislation that says you got to return property. You can't have people kicked out, not kicked out. You can't keep people and tell them to come back. They're going to leave AMA and they're going to leave without their driver's license and their cell phone. Are you kidding me? That's an interesting liability situation. If somebody's going to leave anyway and you're not going to give them their stuff. But we also have the opposite, that somebody can't just up and say, I'm out, give me my stuff. No, there has to be a process where, at midnight, if they say I'm leaving, well, you got to wait until the office opens the next day to get your stuff. You ain't getting it now. So I didn't think we need to flesh that out because it's common sense. You can't say 3 days, and you get your stuff. You can't say, I'll let you out tomorrow night at midnight. I understand having a clinical intervention, maybe. I don't know what the right word is, to say, hey, do you really want to do this? You're doing well, blah, blah, blah. I get all that. But you can't have a contract that says you have to wait 72 hours or 48 hours to get your stuff. The law says you can't do that. The person's parents, can sue the facility, I guess, if something bad happens. I don't know. Normally things like that get fleshed out by, I don't know, Susan Ramsey will tell you that a lot of stuff gets done because nobody wants to suffer the wrath of Susan Ramsey, when she knows when they know that she's going to go after her. So, I'm not suggesting anything. It's not my place. I'm a prosecutor. I don't know civil from Shinola. But what I do know is that the law says you got to give them back their property. The interpretation of the law is it's ASAP, meaning, you're not going to be on the hook if you wait till the office opens and then you get them their property and don't give it to them at midnight. I get that. But anyway, we'll look into that, Steve. And please, anybody who has any thoughts on that, just call me up, let me know, email me. I see that Aaron Arnold is on the call. And Aaron, what is your official position with NADCP? You got to unmute yourself, sir.
My official position is sitting in a Dodge Durango at the top of a parking garage so that I could get enough reception to talk to all of you.
Wow, that's an unusual position with an organization, but I'll buy into it. That's definitely.
I'm the Chief Development Officer at the National Association of Drug Court Professionals. My job is to help essentially to develop new programs to meet the needs of individuals in the justice system who have substance use and mental health disorders.
Okay. And do you want to give everybody the thumbnail of why you're here and what you're doing?
I'd be happy to. So yeah, the reason I'm in a car is because I'm here in York County with my colleagues from NADCP doing our first on-site visit with all of, with many of the justice system agencies here in town for the purpose of developing a rapid response overdose prevention program. I see Dr. Andrick on the call. I'm sure there's others here who I've seen, but so in a nutshell, I'll try to make this as quick and simple as possible. And I'll start by saying what the program is not. So you guys know in your county, you have a drug court. We are the National Association of Drug Court Professionals. We're huge fans of drug court. We do tons of work with drug courts. This program is not a drug court. This program is an early response program. Sometimes people call it a triage program because that maybe gives the idea of what we're trying to do here. We're trying to find people who have been arrested and are getting booked into jail, who are also at risk of dying from an overdose. And there is no shortage of those people, as most of you probably know. So the model that we're trying to work on building here in Palm Beach County was originally created in Buffalo, New York, and it's been since replicated in communities all over the country, large and small, rural and urban. So we're hopeful that it's going to be a great success here as well. The idea is quite simple. We want to screen every single person who gets arrested for their risk of dying of an overdose. And the screening that is generally used for this kind of purpose is not a full clinical screening. It's not a lengthy process, and it's not something you need a lot of specialized qualifications for. It's essentially a 5-question questionnaire. We believe it's going to be incorporated into the jail screening that's already being done. And it's going to ask very basic questions like, have you ever overdosed? Have you ever been treated with medication for addiction treatment? Are you a current drug user? And if so, what drugs? Have you ever felt like you needed treatment? Things like that. I'm saying them inartfully because I'm a lawyer, not a clinician, but the clinicians in the group here are going to help us fine tune these questions. So once we identify the people who screen as high risk for overdose, they're going to meet with their defense attorney. The defense attorney is going to explain to them, we have a new program. It's at no legal risk to you. What it is if you want to be part of it, you'll enter into the program. Your legal case will basically be put on pause for a period of 3 or 4 months. And the purpose of that pause is so that you can work with your treatment provider intensively to focus on your clinical needs and your health and your safety and welfare. If they agree that they want to be in that kind of a program, what happens is we're going to work with the healthcare district to probably have peers who work for the healthcare district go over to the jail or coordinate with the jail and ensure that when those people are released, they're taken directly to the healthcare district to initiate their treatment. At that point, they'd be in Dr. Andrich's hands, and they would do their full clinical assessment there and get whatever kinds of services they need, including medication for addiction treatment, and as well as all the many, many other services they offer. There would be some supervision component because, after all, these people are facing criminal charges. And so we can't really just kind of open the doors and let them out. There's got to be some kind of supervision component. But importantly, this is not a typical pretrial release or diversion program where if you trip up in the process, you're going to get yanked back into jail. We recognize that addiction is a chronic relapsing condition, that many, if not most of the people who enter this program are going to have some difficulties ceasing their use. It's probably not going to be something that happens quickly. Many of them will continue to use. The idea behind the supervision is so that there are eyes on these folks who can detect whether there are signs that the person is in trouble, and that we can respond in a clinical way, to get that information to the healthcare district and do any sort of therapeutic adjustments or other kinds of interventions clinically that need to be done to protect that person. The only instance where the person could run into legal trouble is if they were out and they committed another crime or something like that. But as long as they're, going to treatment and checking in as they're supposed to, they're going to be fine. The idea is that we keep them in the program for 3 or 4 months to get them to a place of just initial stabilization. And again, I'm talking out of school because I'm not a clinician, but the way it's been explained to me is that after about 3 or 4 months, hopefully seeing some signs that their risk of overdose is coming down, they're making some progress in treatment. And then at that point, they're sort of released from the program, although they will continue in treatment, but they're released from this program and their legal case will resume. And that's unique. So most diversion programs are, there's a carrot and stick approach where we say to people, if you join this program and you successfully complete it, we'll dismiss your charges. But if you mess up in the program, we'll catch you and we'll put you in jail. This program doesn't have either of those things. It doesn't have the carrot or the stick. It's simply a way to offer people services so that they can get life-saving treatment. And then once we've accomplished that goal, kept them alive, then their legal case just resumes and all legal options are on the table as far as what happens with their case. So I'll shut up for a minute and see if hopefully that made some sense and see if there's any clarifying details I can give you.
Okay, and this is part of this would be part of a grant program through the NADCP, correct?
Yeah, so the way this is working is that the U.S. Drug Czar's office in the White House, which is technically the name is the Office of National Drug Control Policy, is funding my organization, the National Association of Drug Court Professionals, so that we can work with you guys at no cost to help build this model.
Okay. Anybody have any questions or comments? Just for the record, you know, it's every jurisdiction is a little bit different. Buffalo's got different protocols and different a different bond situation than we do here. From my office's perspective, we are very much in agreement that in the harm reduction aspect of this to save a life, and in the process, perhaps, you know, have an impact on recidivism. But there will be qualifications for being in the program. Somebody who commits an armed robbery is probably likely not going to get in. You know, it's not going to be heavy on victim crimes. It'll be more drug use and thefts. But we'll work around the edges when it's appropriate. You know, especially on first-time offenders. But even if we have 25 people a month that get into the program, or even 20, it's worthwhile if we can save those lives. And kudos to the healthcare district once again for stepping up to the plate and said, "Well, hey, we got the place, and now we can have them go to South County too." Anyway,
So if I can just,
yes, please.
sorry, but like I talked too much today.
No,
But
please.
I just want to say,
You're involved in this. Go ahead.
yeah. So I just want to say this is completely different than drug court. I think like what we have with the drug, how I see this, like I'm familiar with drug court. So there is no, like I know Rebel Recovery, for example, is part of the team around the drug court, and that's a great program and they're doing an awesome job. And I don't think we want to kind of, that's not related to this at all. This is technically screening patients that are in the jail and connecting them as soon as possible to treatment as soon as they're out. So they don't go to the drug court, they just discharge, maybe they're kept just a few hours. Once we have centralized receiving facility, they probably would end up in a jail in the first place, right? So this is just identifying who would be benefit for the treatment, and there is no legal incentive like we have in a drug court. Like in a drug court, they're gonna drop your charges if you go to treatment. Here is really relying on goodwill from the jail to screen them and connect them to the services, and the patients to believe that where they're sending me really maybe can do something good for me. But it's kind of really referral process for mainstreaming treatment for them. And we would have a peer there just to pay them Uber, to convince them to go for the treatment, and kind of follow up if they come to the clinic to kind of eliminate any barrier to access to that care, if that makes sense. But like, you know, from the reason why I'm really appreciating examples of those other programs, because you can learn from other practices. And we mentioned Buffalo yesterday a few times. I think that's a really great example of the program who is doing everything to connect them right there and then because they're highly motivated. So I think that's that kind of immediate connection that in real time, without appointment, peer connects them to the services will be very important. So I think that technical assistant grant that came to our county is very valuable, that we learn from other people practices. And I'm really looking forward decreasing like, you know, those people coming back to the jail for the same charges or even worse charges. So I think that's the goal of this program, to connect them to services and hopefully prevent future incarcerations.
Thank you, Belma. And one of the one of the differences between this program and drug court is it's parallel clinically. So in drug court, if you have a dirty urine, you go back to court and you face consequences. Okay, because that's the criminal drug court, where you have a year-long program, but there are consequences for dirty urine. In this particular case, it would be completely clinical, so that the court or the prosecutor would never know about a dirty urine, because that's part of the treatment program. And I think that would be helpful in terms of the keeping somebody in treatment and making sure that the system, I'm a prosecutor, I'm saying this, but the system doesn't mess it up. Because as we talked about earlier, oops is part of recovery. So relapses are part of recovery. So I think that's one of the main things I see making this not only different from drug court, because drug court can be referred to rebel recovery, for example, or to DAF, for treatment, but they're still returning to court every week to report in. And this is basically, okay, this is your opportunity, and everybody's going to try to help you in a clinical manner. So anyway, Aaron, thank you very much. Safe travels back to DC. I'll see you on Friday at the roundtable. And you're muted, but thank you. Okay, any additional comments today?
Nancy McConnell.
Oh, Nancy, I'm sorry, you had your hand up. Go ahead.
Hey, I just wanted to say that I know Aaron we've been playing tag with a couple of my employees trying to set up a meeting. But I think it's really important that as Rebel is in first appearance, now arraignment court, specialty courts, and with a program inside the jail that offers medication-assisted treatment while people are serving any time in jail, that I just wanted to let Belma and Aaron know that we are here to support in any way, because we have been working in this system for a long time as peer supports. And so we're available if y'all need any support. That's all.
Awesome. Thank you, Nancy. And I'm looking forward to talking with your staff. I got another email from them on the drive over here, so we will connect. Thank you, Al. It's great to talk to you all.
Okay, safe travels, buddy.
Thanks. Bye-bye.
Okay, thank you all. Any additional comments from the task force? And now any comments from the public? Anybody have a comment to make? Okay. Uh-oh, somebody's trying to chime in, but they've got bad reception.
Oh, it might be Dr. Lori.
Lori, is that you, Dr. Vinacore?
Oh, thank you. Thank you. We're so long.
Okay, you're good. All right.
Yes.
Not for nothing, we're out of here almost an hour early. So my goal has been reached. Hey, good meeting, everybody. Thank you so much for your input, and let me know if you need anything.